Yes, please.
Was it, hopefully it was what you expected more or less, I hope.
We didn't know what to expect.
What's that?
We
You
didn't
know
know
what
what
to expect? Quiz on diuretics?
Study what?
Question number 1, and I don't have this in PowerPoint, so I'm just going to have to read them off. ARBs block the activation of the AT1 receptor, causing vasorelaxation by inhibiting the stimulation of which G protein? Even if you didn't know what in the world I was talking about, what ARBs were, you still should have got this question right. And that's GQ.
Yeah.
Okay. High or low plasma sodium levels stimulate renin.
Low.
Oh. Sympathetic nervous system inhibition by beta blockers does what to renin release? Decreases it, right? Stress pathway for causing increases of renin secretion through beta receptors. AT1 receptor activation stimulates. The answer is growth factors. Because remember, the important thing about these guys is, when you have this overactive renin-angiotensin system, it can stimulate cardiac remodeling and that sort of thing. Okay, ACE inhibitors cause bradykinin levels to increase. Okay. Diuretics. Which diuretics block the sodium 2-chloride potassium transporter? Loop diuretics, right? And then the sodium chloride symporter is thiazide diuretics. And then the amiloride sensitive sodium channel or potassium sparing diuretics. What part of the tubule system is that at?
The collecting duct.
Collecting ducts distal area, okay. And then which diuretics block sodium bicarbonate reabsorption? Carbonic anhydrase inhibitors. And increased renin-angiotensin system activity has an antidiuretic effect. Okay, it's involved in conservation of water. All right? And the 3 Powerpuff Girls are Bubbles, Buttercup, and Blossom. Who wrote Blossom exclusively? Did it? You got Bob?
One person.
There's something to be said for being an outlier, right? Okay. The plan. I'm going to try and I don't think I'm going to get all the way through this antiarrhythmic lecture today. And as you see on Friday, we're scheduled to do coagulation. And then again on Monday, I'm going to just do a brief review of antihypertensives. I'm going to decide on Friday how far I get through that lecture, how much of that is actually going to wind up on the exam, or how much might wind up, as was suggested by a colleague of yours, on a quiz or something like that if we don't get through it all. Okay? So there's still going to be an exam on Wednesday. How much of the coagulation stuff gets on there will be decided on Friday. Okay, and I believe Dr. Taberge is covering those agents, or has he covered them?
He's been covering them.
Okay. And he's also covered some of these antiarrhythmic agents. I know he handed me a slide he's giving you guys, or has already given you guys, I think. So, and it looks like, some of his information is actually beyond what I'm going to go into in this lecture. And the key thing is, in terms of all the lectures you get this semester, from me anyway, this stuff might be the hardest material because, it's heart electrophysiology. People spend their lives studying heart electrophysiology and the nuances of it, and we've got, an hour, and, so it's just, but you want to understand this stuff at least at a fairly, in-depth level, at least enough so that, when you're a pharmacist, whatever, consulting with this stuff, a little bit of what's going on with these drugs. Okay, so we'll try our best. Okay, did I finish right around here, I think, or was I don't think I guess it doesn't matter. I'm going to start right here anyway. So you guys remember the heart conduction system? Probably covered it in anatomy, physiology, and or in pathophysiology. And you remember the SA node is the node that does what?
Pacemaker.
It's a pacemaker. The cells there spontaneously depolarize. They have those action potentials I talked about on Monday. Those drive the pace of the heart, and then that signal makes it over to the AV node, and it makes it over there fairly fast. At the AV node, that the cells there are involved in receiving the signals from the SA node and then spreading those signals throughout the rest of the heart conduction system. So sending those electrical signals to the heart muscle itself so it can contract in a coordinated fashion. Okay, and guys remember, I went over, well maybe I'll really quickly go over this one again, the heart action potential, just as a kind of reminder of what's going on here. This also brings up some of the targets of drugs. So, as you'll remember, resting potential of cell involved in heart electrophysiology, electrical signaling in the heart, has a pretty low resting potential. Here we got it at minus 96 millivolts. You can read anywhere from minus 80 to minus 90, 100. So pretty low resting potential here. So, and then these cells, of course, we can pretend this is an SA node cell. These cells will spontaneously have action potentials. So what happens with the action potential is that sodium channels are opening up. You'll get some depolarization to go on. You reach certain threshold, right, where these voltage-gated sodium channels are going to open up. Voltage-gated sodium channels open up. Sodium rushes into the cell, and you have this rapid action potential, so rapid change in the electrophysiology of the membrane, such that it goes from way low to much higher. So you've got a big change, and this is all due to ion flows, and initially largely due to sodium rushing into those cells. You'll get a peak about plus 52 millivolts. Then what's going to happen is you're going to get some potassium channels that are going to open up, and chloride channels open up. But this isn't like a big, huge effect, though. So you've got this notch that occurs. So you've got a little bit of repolarization going on, but then it's going to be in a holding pattern, right? And that holding pattern is largely due to these other channels opening up, calcium channels. So calcium's coming in, which is going to keep this cell from totally repolarizing and going back down. Potassium will leak out. Then, you're going to get this repolarization phase here, and largely what's happening here is potassium's going out, and you've got that sodium-potassium pump as well working to kick the sodium back out. Okay, and this is what's happening like at the individual cell level, right? As opposed to what you see with an ECG. Okay, and there's that. Okay, so when during these action potentials that these cells are going to have, what's going to happen initially, those sodium channels are going to open up. So sodium ions are going to accumulate inside these cells. Potassium ions are going to deplete. So a big player in keeping these heart cells working like they're supposed to are the sodium-potassium pumps, which are involved largely in the repolarization phase, right? So they exchange 3 sodiums, take 3 sodiums back out of the cell and bring 2 potassium ions in. And that helps keep the ratios such that you can get this regular action potential, these regular action potentials occurring. Intracellular calcium levels typically get kept pretty low in cardiac cells. But when you have these channels open that are allowing for calcium to come in, among other things, you get channels open for calcium to come in. That stimulates calcium release from sarcoplasmic reticulum, and then that's calcium, of course, is what's going to be involved in the contraction that's going on. Then the calcium levels, of course, are going to have to be pretty much exquisitely controlled in the cells for all this to work right. So calcium is removed by a couple of different ways. There's a calcium pump that restores calcium back into the sarcoplasmic reticulum. And then there's a sodium calcium exchange mechanism that exchanges 3 sodium ions for 2 calcium ions, and that pump also works. Do you guys remember which drug actually affects the activity of the exchange of sodium and calcium? Remember this guy? Cardiac glycosides. We'll go over them again in a minute. So, it's an indirect effect. Okay, so and kind of a key point in terms of arrhythmias anyway is that if somebody's got dysfunctional or abnormal regulation of calcium in myocytes, that can of course contribute to arrhythmias. Okay, in terms of propagation at the level of the SA node, the impulse there spreading of course over to the AV node is going to depend on the magnitude of the polarizing current and also the cell-to-cell electrical connection geometry. So if things are working right, you know, the magnitude of this current, so that basically the magnitude of the action potential is going to be sufficient. If there's cell damage or something there at SA node, that can be disrupted. And that can, of course, affect normal heart rhythm. Another thing that's important in terms of SA node, and really through electrophysiology or electrical signaling in the heart in general, is that you know, these things are, you know, these are pathways we're talking about here. You know, the anatomical pathways. You know, you've got that are involved in the spreading of these electrical signals, and so if there's any kind of damage that's going on, you know, from myocardial ischemia or some other type of damage, that's going to affect the normal flow of the electrical signaling in the heart, and that can also be involved in causing arrhythmias. And you know, of course, all these electrical signals need to be moving really fast, right? You know, to get the heart to beat in a coordinated fashion. So the electrical impulses here are spread by way of gap junctions. Remember how does the electrical signal spread through gap junctions? What's happening there? You guys remember that one? Gap junctions are like these super tiny little junctions between cells, right? And so basically the electrical signal is just jumping from one to the next through these tiny little junctions. Okay. Once the signal gets to the AV node, it's going to slow a little bit, and that's largely due to an inwardly rectifying calcium channel. That's, and so what happens here is the signal slows getting to the AV node, and that actually, the big point here is that allows for atrial contraction to propel blood into the ventricle. So you don't want that message, the electrical signal, to get past the AV node too fast. You need some time there. Okay, once the impulse then leaves the AV node, it's going to enter that conducting system where calcium currents typically tend to be larger and the impulse is going to spread faster. So that, you know, once you get past the AV node, the message, the electrical signal to the rest of the heart, so that it happens really fast. And again, if that's not working right, that's when somebody starts to have an arrhythmia. Okay. I never know, and I'm going to go over the ECG really briefly. Have you guys like been in a lab or anything like that for ECGs? Are you familiar with those? Something you've been over them though. Okay, so I'm just going to super quick go over them. It's not something that, you know, that it's of course important, but it's not something we have a lot of time to spend on. You guys remember that ECG, the rate of the ECG, the heart rate that you see in an ECG is going to reflect SA node automaticity, and then we've got the PR interval that shows the duration of the AV node conduction time. QRS duration reflects the ventricle conduction time, and then that QT interval, I of course have a picture of this in a sec here, reflects the ventricular action potential duration. So that the depolarization through repolarization. So this is what you see with a normal ECG. So we've got the AV node conduction time, so that signal again slows down at the AV node. That's the PR interval. Other important thing is the ventricle conduction time, so that ventricle action potential here. That's the QRS complex. And then we have this QT interval. That's the whole thing, right? That's the action potential that you've got going on, and plus the repolarization. Okay. I'm not going to test on this stuff, right? But I will test on this part though, refractoriness. So refractoriness is refractoriness when you're talking electrical signaling. Okay, refractoriness is the cell has an action potential. The refractory period is how long is it until you get another action potential, right? And one thing you see with people with arrhythmias is they have, can have a super short refractory period, so those cells will fire really rapidly, and that's due to like ion channel dysfunction, that sort of thing. So, and the refractoriness is largely going to be determined by voltage-dependent recovery of sodium channels from inactivation. Okay, so remember that having an action potential, those sodium channels open up, then they'll close back up again, and the period they're inactive is important for establishing that refractory period. And then, as you'll see, again, a lot of people with arrhythmias, they're going to get flutter and that sort of thing. So, those cells are trying to have action potentials too rapidly in sequence, and so some of the drugs are going to be, well, the same as local anesthetics. In fact, local anesthetics get used for helping to control arrhythmias by you're blocking those sodium channels. You block those sodium channels, keep them inactive a little bit longer. That stops a second action potential from occurring too quickly. Okay. Various stimuli can interrupt sodium channel activity and overall rhythmicity. The effective refractory period is the shortest interval at which a premature depolarizing stimulus results in a propagated response. So what that means is your cell has an action potential. Okay, you've got this action potential that goes on, and then for some reason you have a inappropriate calcium influx or whatever. So the effective refractory period is how long that cell will wait until it has another action potential. Okay, and then this is used to describe how different agents can affect electrophysiological activity at various cardiac tissues. Just some more really basic information. At the AV node, you got calcium inactivation is regulated by time. So even when there's resting potential that can get re-reached, not all calcium channels are going to be done being inactive, and that'll help stop having another inappropriate action potential. Briefly, what this means is the extra depolarizing stimuli shortly after a repolarization is going to generate a reduced calcium current, and that's going to change the way the electrical signal is sent. Okay, and then if you have an extra stimulus applied later, that can actually cause a magnified calcium current, and that will also disrupt the normal conduction of the signal. Okay. And again, kind of seeing some blank faces out there, but you're not going to walk out of here knowing this stuff. It's good. You got to really study this stuff to get the basics down. Okay, I don't know any other way to do it other than make this class, the rest of the semester based on heart electrophysiology. So do your best studying this stuff, and if you look at my study guide, which I don't think I've posted, but you should be able to walk yourself through this stuff and understand it. Okay, in terms of arrhythmias are going to occur when the sequence of an impulse initiation or propagation is disrupted. Essentially, the generation of the initial signal is going to cause the heart to be screwed up, or the spread of that signal is screwed up. Okay, and if you have initiation failure, that can result in a slowed heart rate. So the SA node cells are firing like they normally would. They slow down. You can have a slowed heart rate. You can even lose a beat of the heart. Okay, if they don't fire correctly. Okay, the three mechanisms that underlie arrhythmias that have been elucidated are enhanced automaticity. So essentially what that means is SA nodes are firing rapidly than they should. Okay, so you get that automatic firing of those guys. It's going to happen too quickly. You get after depolarizations and triggered automaticity. So after depolarizations are, the cells are supposed to be in a refractory period, but then some signal will stimulate them to try and fire again. And that's, one big issue where you get start getting arrhythmias. And then another problem is re-entry, which is altered propagation. So and I have some slides down the road that show this. So what happens is the electrical signal is being sent throughout the heart, but then say there's some kind of physical barrier or whatever, and those signals will then be sent, go backwards and all over in different directions. So basically, the spread of the electrical signal will be disrupted, and it'll start going backwards and what have you, and the tissue won't know how to respond correctly. So enhanced automaticity, again, that can occur largely in the SA node. It also can occur in the AV node. So essentially, remember those are the cells that can spontaneously have action potentials. After depolarizations, these guys are going to occur when the cardiac action potentials are interrupted or following an abnormal depolarization for some reason. Sodium channels don't stay closed long enough, and they reopen up, and you get this depolarization. You then hit threshold, and the cells try to have action potentials again, and the electrical signaling gets screwed up that way. And again, reentry is when you have an electrical impulse that's going down its normal pathway, and then it runs into some physical barrier or what have you, and then the signal inappropriately gets sent the wrong direction, gets sent back or what have you. And in any of those ways, of course, then the muscle cells aren't getting the right electrical signal to contract all together like they're supposed to. Okay, this slide just shows, in real simple terms, what happens with after depolarizations. So this is where the cells are going to try and have an inappropriate action potential, essentially. So here, okay, this is, again, right here, you've got this normal heart cell action potential, right? So you got this going. What happens with a delayed after depolarization is you get down to this refractory period, which is supposed to last a while, right? But that doesn't happen, and you get this after depolarization that occurs, and the heart muscle is not getting proper signal, so you can get like a flutter going on. Early after depolarization is, under normal circumstances, you're going to get total repolarization, right? What happens is some kind of a signal, ion channels opening or whatever, it's going to keep this action, the repolarization is going to last longer than you want it to. And so what can happen then is with a delayed after depolarization, you can get an inappropriate action potential type activity that'll occur. The heart's not going to, be beating in a coordinated fashion. Yeah, almost kind of a similar thing with an early after depolarization. You can stimulate another attempt at an action potential anyway in these cells, and that also screws up the signaling throughout the heart. Okay, this slide shows reentry. So what happens in this top part is the normal situation where an electrical signal will be coming down, and the signal, as these little arrows show, spreads throughout the tissue the way it's supposed to. With reentry, what's going to happen is you get the electrical signal that'll come down, and there'll be like areas that the signal's not going to get to that it would normally get to. So those areas won't respond, but then you won't get that. Up here, you've got the signals coming back, and they run into each other and basically stop each other, right? But here you have this part here is not working right, so the electrical signal then is going to travel on to areas and stimulate areas that electrical signal wasn't meant to stimulate, when things were working right. Okay. A lot of times with that, that's caused by physical issues. You've got, scarring of the heart tissue or whatever. Somebody's got myocardial ischemia. Okay, and I'm a little bit more familiar with this than I am with the Powerpuff Girls. Is this show still on?
Mm-hmm.
Yeah, really? Okay. I used to watch that as a graduate student in the 90s. amazing what lasts. I don't know if that's good or bad. All right. In terms of antiarrhythmic drug mechanisms of action, the next few slides are, really some just basic and pretty general information, mechanism of action. Super key point in terms of the use of these guys, the effects of antiarrhythmic drugs are very complicated, and one big thing when you're giving somebody an antiarrhythmic is it can cause arrhythmias too, because you're messing with different ion channels and ion channel activity, and there can be, I think, a little bit of trial and error goes on when you're trying to treat people for arrhythmias. Okay. The two major mechanisms that get used to block arrhythmias are the inhibition of the development of afterdepolarization. So another way to say that is prolonging refractoriness, right? For instance, if you keep voltage-gated sodium channels closed longer than they normally are by, say, using lidocaine, a sodium channel blocker, you do that, and then you're going to stop inappropriate afterdepolarizations to occur. So the refractory period before these cells are going to fire again is going to be the proper length that the heart needs to function well. Okay, and then another way is interference with inward calcium or sodium currents that are responsible for upstroke. So essentially stopping those depolarizations, premature depolarizations from occurring, okay, by blocking sodium channels, calcium channels, what have you. Okay, in terms of re-entry, the drugs that are going to stop arrhythmias are going to block inappropriate action potential of propagation. So you're kind of trying to gloss over the weak links, the tissue damage, etc. You're trying to reduce the amount of damage that does in terms of the overall electrical signals. Okay, so again, a lot of the drugs that get used for arrhythmias are going to block sodium channels, going to keep them inactivated longer than they normally would. So what those things are going to do is, and you can almost get rid of half this sentence, drugs that block sodium channels prolong refractoriness. So you don't have another inappropriate action potential and an inappropriate electrical signal sent throughout the heart. Agents that increase action potential duration by non-sodium channels means also typically do the same thing. Typically they're going to prolong refractoriness as well. There's a general theme developing here called prolonging refractoriness, which is why I did this in italics. So agents that interfere with cell-to-cell coupling, so the spread of signals, are also hypothesized to prolong refractoriness. Okay, and then accelerated conduction in areas where it is usually slow. So there's some drugs that are meant to help speed things along. Actually, that inhibits re-entry from occurring. Okay, and so it doesn't allow for altered propagation to occur. Okay, state-dependent ion channel blocking drugs bind ion channels at specific sites. So basically, what I'm saying here is drugs for arrhythmias that are going to typically target anyway, ion channels. Okay, and we'll go over this a little more. And also, the dissociation rate of ion channel blocking agents determines the steady state block sodium channels. What I'm talking about here is, and if you want to think back to, I think, if you guys remember how local anesthetics work, remember, they get pass through a membrane, and then they get back up into a sodium channel. Once that sodium channel has been opened, right? So how long they actually stay in there is going to, of course, affect, how much they affect refractoriness, et cetera, how much they're going to affect normal function of those cells. Okay. As heart rate increases, those sodium channels are opening more often, right? That's actually, and the more often they're open, the easier the drug gets up in and closes them. You lose that chance for those drugs to disassociate, right? So that can affect how the normal function is going. And that, again, that allows for an increase in the time of blockade, because the drug is sitting up there in those sodium channels for longer when heart rate sped up. So that's going to, in turn, actually decrease, kind of normalize things a little bit. Okay, now that this data is confused, again, you're going to have to just, I don't know any other way to say it, but you're just going to have to go over this stuff yourself and think it through before I think you really understand it. Now I'm just going to start going through the antiarrhythmic agents that get used and their basic mechanism of action. Okay. So in terms of general classifications, which I believe is what Dr. Taberge or Taberge or the Berge, many things, I don't know. We used to go back and forth on each other's names a bit, right? So I get called Selvage a lot, right? I like Selvaje a lot better, so you know, people used to call me that when I go to Spain or whatever. So I thought Taberge, I thought he'd be excited about that, but he wasn't. So, anyways, so he did give you guys a slide that I think shows, you know, classes of drugs using these classifications. So the big classifications that you want to be aware of course, are sodium channel blockers. You know, and then I think sodium channel blockers really, I think, easiest for all of us here is going to be think back to how local anesthetics work. Okay, action potential blockers are out there as well, you know, and they're usually actually going to block a potassium channel. Okay, so again, action potentials are, you know, a lot of coordinated activity of ion channels going on with action potentials, and blocking potassium channels can do things like increase the duration of an action potential. So, and if you increase the duration of an action potential, that decreases the ability to cause another action potential really quickly, right? Okay, and they'll actually reduce automaticity some. Okay, calcium channel blockers get used as well. Their major effects are in slow response tissues, as well as SA and AV node. And these guys can actually increase heart rate by reflexive sympathetic activation, among other things. Okay, and again, we'll discuss these a little bit further down the road here. And beta blockers also get used, as you might suspect, for arrhythmias. And you guys know how beta blockers work, right? What's the beta receptor in the heart?
Beta 1.
Beta 1, right? And it couples to GS. And beta blockers stop the activation, among other things, or stimulation of these GS proteins, and that is going to slow. Amen. Okay, that's going to slow down the heart, right? It's going to slow down the heart, and it's going to decrease how hard the heart muscle contracts. That's pretty good for waking people up, though. You need to stay awake for this now. Okay, so beta blockers are going to reduce heart rate. They're going to decrease intracellular calcium overload, you know, essentially through a similar mechanism, decreasing activity of those cells. Okay, the first specific drug I'm going to cover, having said all that, is adenosine. Okay, so adenosine can be given like in an IV bolus to stop reentrant supraventricular arrhythmias, and can also be used to produce controlled hypertension and some surgical procedures. So what adenosine does is it activates the adenosine or purine receptor, and the activation of that receptor in turn, and this is complicated, activates an acetylcholine sensitive potassium current in the atrium, SA, and AV node, and it's also coupled to GI. The purine receptor, the adenosine receptor, couples to GI, and so you're going to inhibit cyclic AMP, second messenger signaling. Super big picture, what happens with adenosine mechanism of action, you know, it's almost like you think of beta blockers in reverse, right? So you're activating the adenosine receptor, purine receptor, right? That guy couples to GI. So, and in these heart cells, right, instead of getting increased cyclic AMP like you would with second messenger signal or beta receptor activation, you're getting decreased cyclic AMP, second messenger signaling, and then you're going to decrease how hard the heart is working. Okay. I'll leave it at that, pretty simple. Okay, so the net effect when this stuff is given is you're going to shorten the action potential duration, and you're going to slow automaticity. You can also, as you think about it, the heart slowing, you know, you've got your body sensing all kinds of stuff. You can get some sympathetic activation that occurs in response to this. And the adenosine gets used, it's short-term use because it gets rapidly deaminated. So the big picture is, you know, you give this stuff, somebody's having, you know, some serious heart issue or arrhythmia issue, you can give them an IV bolus of adenosine to try and at least stabilize that. Okay, and basically you're slowing the heart down. Right? Okay, I'll at least cover this guy. Amiodarone.
Amiodarone.
This is another drug. Am I pronouncing that right?
Amiodarone.
Amiodarone. Okay. Amio. Okay. How would Blossom pronounce it? I don't know. Okay. This is not important. I'm not gonna test on this, but it's an analog of T3, right, which is the active thyroid hormone. Okay. And it might have some effects that are due to its interaction with thyroid hormone receptors, but we don't want to concern ourselves really with that so much. What happens with this drug is that you're going to slow the SA and AV node conduction, and you're largely doing this by blocking potassium channels. So if you're blocking potassium channels, are you speeding up or slowing down repolarization?
Slowing down.
You're slowing it down, right? Because repolarization is largely you've got potassium, you know, moving around, and potassium, the normal electrophysiological gradients of potassium are what largely help set that initial minus 96 or whatever millimoles. So with this, you're slowing down conduction, okay? And this helps with maintaining sinus rhythms in patients with afibrillation. Okay, you guys know the difference between flutter and fibrillation. So with afibrillation, the cells are trying to have action potentials, but in an uncoordinated fashion, whereas flutter, they're trying to have action potentials in a coordinated fashion, and that causes, you know, the heart to either go with flutter, go in a coordinated fashion. With fibrillation, you know, basically kind of all this crazy activity that's going on as those ion channels aren't working right and not controlling the heart muscle correctly. Okay, and this stuff can be given IV for things like acute ventricular tachycardia or fibrillation. Okay, it does have some nasty side effects, and like you would probably think any of these drugs, you're messing with the way the heart works. So you can cause hypotension with this guy, as well as depressed myocardial performance. Heart muscle's not working right because, of course, you know, you're changing repolarization. Okay, and long-term therapy, and again, I'm not going to ask therapy-type questions. This is just here to hopefully help guide you through this stuff a little bit. Long-term therapy, you can get some accumulation of this stuff, and can actually cause pulmonary fibrosis, which is not good. And it can cause death. If somebody has an underlying lung disease, et cetera, that can make this more likely to happen. You know, bottom line really for us is if somebody has a lung issue, you might not want to give them this particular drug. Okay, and I stop there. Cardiac glycosides, we've already been over once. We're going to discuss them on Friday. I'm guessing we're not going to get too far into the coagulation stuff. So again, I'll play it a little bit by ear, but that might not line up on the test. I don't want to put too many lectures.